Oxford overviews and EBCTCG analysis, which have shown that irrespective of the ERPR status, irrespective of the nodal status also across many patients, you have a benefit of adjuvant chemotherapy per se. So chemotherapy is also equally important for these patients. So adjuvant has shown significant benefit, and the thought that neoadjuvant therapy was supposed to control the systemic micrometastasis early was introduced by Bernard Fisher by his theory that hypothesis that breast cancer is a systemic disease at inception, and that is why there was an effort to improve outcomes by giving neoadjuvant chemotherapy. So now looking at what is the evidence to offer breast conservation surgery in the post-chemotherapy setting, we today practice neoadjuvant chemotherapy across two groups of patients. One is locally advanced breast cancer, which the West sees very few of, but in India we still see 30 to 40% of our patients are locally advanced breast cancers, which is T3, T4 or large nodal burden or N3 disease. We also use a lot of chemotherapy now in early breast cancer, which is T1, T2, N0, N1 patients, when they are triple negative or HER2 positive, when they are node positive, when we have poor breast to tumor ratio so as to achieve downsizing and then maybe achieve breast conservation surgery. So again, coming back to post-chemotherapy surgery, we need to look at it in two perspectives. One is a locally advanced breast cancer and one is early breast cancer. So for locally advanced breast cancer offering breast conservation, there is no evidence. There is no level 1 evidence. Since we saw a very beautiful progression of randomized trials of radical mastectomy to modified radical to breast conservation surgery, to maybe also enough data to say oncoplastic surgery is safe, we don't have that kind of high-level data because again, locally advanced breast cancer is not a problem of the West, so you don't expect the data coming from them. But we do have large amount of retrospective, prospective studies even from our center, and although the level of evidence is low, we know that in select cases, you may be able to offer them breast conservation surgery without any detriment in outcomes. So even early breast cancer post-chemotherapy, there isn't any randomized data to say that you need to give chemotherapy and that improves outcomes. So all the data for breast conservation surgery is extrapolated from data of upfront BCS trials, and also inferences are drawn from randomized trials conducted which actually compared adjuvant and neoadjuvant chemotherapy where BCS was not the primary endpoint. We still give NACT in early breast cancer either to improve survival or achieve downsizing to be able to prognosticate the patient and offer further risk-adapted maintenance chemotherapy in patients who have no pathological complete response. And of course, there are certain practical situations that in younger patients, you are awaiting germline reports, you're planning reconstruction, you're offering fertility preservation options. So all that just buys time when you're planning neoadjuvant chemotherapy and then surgery. However, if you look at this EBCTCG meta-analysis of Lancet in 2018, as such adjuvant versus neoadjuvant chemotherapy was compared, there was no survival benefit. But downsizing was achieved. This downsizing was still not 100%. So 25% increase in the BCT rate. So from a 45% BCT rate in the upfront setting, it was 60% in the post-chemotherapy setting. So not that all 100% patients were able to have BCS post-chemotherapy, but yes, there was a 25% increase in the rate of breast conservation. If you look at the increase from mastectomy, patients who were planned for mastectomy earlier, 33% of them had breast conservation later on. And patients who were planned for breast conservation only earlier, 87% of them had breast conservation. I'm just slightly worried about those 13% who were planned for breast conservation therapy but who had mastectomy. And if you see majority of them here, 25% had progressive disease or stable disease. So there is this subset of patients who's not going to respond to neoadjuvant chemotherapy and who probably may benefit with surgery first. So when you have this practical situation where you see a mammo like this and that's a large mass there, you're going to generally give chemotherapy in a young patient, grade 3 patient to get adequate downsizing and do a better breast conservation surgery without having to impair the cosmesis too badly. And this is another 26-year-old who had a large TNBC pushing borders, non-infiltrating kind of disease. When you give chemotherapy, they shrink enough. It's the same patient's mammo, believe me. So they shrink enough and you are able to offer them breast conservation with a better cosmesis. Now the fear for post-chemotherapy breast conservation has been this, that tumors don't shrink concentrically. So this is what you would love to happen as a surgeon, but that doesn't happen. This is something that may happen and we don't have, of course, imaging can help us to a large extent, and now with MRI coming in, it may add to our confusion sometimes, but yes, it does help to add to our confidence when you're planning post-chemotherapy breast conservation surgery. So this is the main problem of patchy response, or Swiss cheese kind of response. That is the fear for planning post-chemotherapy conservation surgery. So does this downsizing of tumor affect local recurrence rate? So we have data from NSAP B18 and B27, which were the first pivotal trials of AC given before surgery versus after, and then 27 where taxane was also added in the pre-surgery regimen versus later. And the 10-year cumulative incidence of loco-regional rate was 12.3% for mastectomy and 10.3% for lumpectomy. So it seems like it was comparable. And the factors that affected this was age, pre-chemo T size, end stage, and the response to chemotherapy. So again, that's why response assessment becomes an important part of this, that I think a medical oncologist should themselves also examine the patient after each cycle. So for teaching purpose, when I tell my residents, when do you assess response, it's not at the end of 4 cycles or 6 cycles. At every cycle, you need to really assess response. But it did show an increase. The EBCTCG meta-analysis, which looked at BCS done upfront versus BCS done post-chemotherapy, there was actually a 6.5% increase in the local recurrence rate. Of course, this study has a number of caveats, and I'm not going into the details. But even when you take care of the caveats, there was still a 3.2% increase in local recurrence when BCS was done post-chemotherapy, and that's an important point to note. And it was 30% when surgery was omitted. So it was unacceptably high when surgery was omitted from the post-chemotherapy planning and only radiation was given. There were 2 trials which actually tilted the balance towards it, towards a poorer outcome in this meta-analysis of 11 randomized trials. So the other benefit of giving NACT before is to be able to prognosticate. So even in the B18 and B27 studies, which were the earliest studies of this, there was no difference in outcome when chemotherapy was given before or after. It was with taxane also, there was no difference. However, there were doubling of PCR with more NACT. So if it was 15% with anthra and cyclophosphamide, it became 30% with taxanes were added to the preoperative chemotherapy regimen. However, that did not lead to an improvement in outcomes at the trial level at least. So we are able to, yes, prognosticate the patient at an individual level when they respond exceptionally well to chemotherapy, but we are not able to use PCR as a surrogate of disease-free survival or event-free survival, even across the worst molecular subtypes like triple-negative or HER2-positive breast cancer. However, with the Catherine trial and the Createx trial, which are now telling us that, identifying PCR may be actually a way to be able to triage patients to get more chemotherapy in the maintenance period. So risk-adapted maintenance chemotherapy may be the way to go, is what the current belief is in early breast cancer also, especially in the triple-negative and locally HER2-positive patients. So BCS in locally advanced breast cancer, again, locally advanced is a very heterogeneous group. You may have just a mild pudorrange to some infiltration of skin, to local ulceration, to a tumor which is very true to only Indian subcontinent where I call it T10, it's beyond T4. So you cater to all these patients. So that is the spectrum of locally advanced breast cancer for us. We generated some data back in 2008 and 7 where we said that breast conservation is safe. So this was a cohort of 1,400 patients with a median tumor size of 7 centimeter after NACT. The PCR rate was 8.3%, BCS rate was 30%, but we said that BCS is possible, and the patients who had BCS actually did better. But that is clearly a bias of biology. The patients who responded well to chemotherapy only had BCS, so that's why they did better. So this is to be taken with a pinch of salt, but this just proved that we could do breast conservation surgery if you select your patients well, but not across all. Further down, this is something that we analyzed in 2017, where our PCR rate then improved to 22%. So from the 8.3%, we improved to 22% because a lot of patients then got taxanes in the preoperative regimen or even got trastuzumab, which was not the case earlier for us. The breast conservation surgery rates then in our 2017 cohort were 42.3%. So it's still not 100%, but we are able to achieve half the patients of locally advanced breast cancer. We are able to do a BCS with adequate safety even with respect to disease-free survival. Similar data exists from MD Anderson also, where they looked at post-chemotherapy breast conservation surgery in locally advanced breast cancer and it seems to be safe. And these are the few factors which actually affect the local recurrence or the long-term recurrence rate. So today in our practice, 50 to 60% of breast cancer patients will require neoadjuvant chemotherapy. And often you come across a situation where it is a triple-negative breast cancer, whether they have 1 tumor, 2 tumor, you are able to clip them. And after the chemotherapy, even with carboplatin in the neoadjuvant regimen now, there is a near complete response. You localize the clips and you are able to do a breast conservation surgery, which is cosmetically better for the patient. And she was also a triple-negative young patient, so she got through her genetic reports, etc. So it's another patient of triple-negative breast cancer with a BRCA1 mutation. You can see a large tumor on the left side and a smaller one on the right. and post-neoadjuvant chemotherapy, all that was left for us to remove were the clips. And when with this kind of clipectomy and a specimen mammography done to confirm that the clip is removed, we had very little surgery for her, so her cosmetic outcomes do improve when you give chemotherapy. Whereas you come across a situation like this, where there's a strong ER/PR positive tumor, ER8, PR8, and all-red scores very strong positive, and this is her post-chemotherapy mammo, where they don't respond. They don't respond that well to chemotherapy. So you still end up doing a breast conservation surgery with a latissimus dorsi flap in patients who are really keen on that. Whereas you have a situation like this, where these are multicentric tumors and the skin thickening and everything that you can see on mammo, this patient needs a mastectomy, it's a no-brainer. Some patients who are, again, ER strong positive, PR positive after NACT, they remain the same. The tumor doesn't really shrink. And then they end up with a breast conservation surgery with some kind of a reconstructive surgery. And we are able to do even oncoplastic breast conservation surgery post-NACT. So factors to consider for planning breast conservation after chemo are accurate clinical and radiological mapping of disease before you begin chemotherapy, mark the disease extent with clinical diagrams, pictures if you need, and clip placement whenever necessary, and do a good response assessment at almost every cycle. It's vital for the surgeon to see the patient before starting chemotherapy, because if chemotherapy has been started earlier and if there is no mammography, I cannot offer the patient breast conservation surgery, it is risky. So we need to do a good clinical radiological assessment of disease before starting chemotherapy, that's quite important. And of course, post-chemotherapy BCS is a shared decision making between the patient and doctor. You need to counsel them, consent them, and they need to understand the risk involved. You need to put clips. Yes, you need to put clips when you have a triple-negative breast cancer, when you have multifocal lesions, when you have deep-seated tumors, and when it is a USG-guided biopsy. Otherwise, in strong ER/PR positive patients or those who have microcalcification like the HER2-enriched ones, you may not put a clip because they will always leave behind some residual architectural distortion or disease. So are we coming to an era of no surgery post-chemotherapy yet? There have been trials which have looked at no surgery and only radiation with a boost in post-chemotherapy setting, but they have failed to yet have a good local regional recurrence rate. They are exceptionally higher, 25 to 30%. So how can we probably triage patients to have no surgery if you have PCR? But PCR is something that we come to know only after surgery. Without you operating, his pathologist can't say. So how do you predict PCR? If we are able to predict PCR accurately in future, we may be able to get to a point that in exceptional responders, you may get away without surgery. I'm not yet saying that we are there, but maybe in future we may get there in triple-negative breast cancer. So you do an MRI, and when you look at MRI and the multiple studies that have happened for MRI, it really has an overall accuracy for predicting PCR of 76.68%, not 100%, and it is maximum in triple-negative breast cancer as you would expect it, and it's quite low in HR positive and HER2 enriched is almost 60%, so you can't really use MRI there. So then you can tap on your pathology colleagues to tell you if there is PCR or not, and then the radiologists say that, okay, we'll do vacuum-assisted core biopsy, we'll do 12 core biopsy with a large gauge needle, and if there is no tumor in that, then maybe the FNR is 5% that it is indeed a PCR. But that's like the radiologist doing a breast conservation surgery with a needle and with a good margin. So, I mean, it's redundant. I don't think it's no surgery, it's radio surgery. So, unfortunately, the PCR rate is still 40%. It's not 100% at best. So, we can't get away without surgery yet as of now. But MD Anderson is running a prospective study, which is called Exceptional Responder Study. And they have data where they have not operated on these 58, 60 odd patients. And at 25 months, there's no IBTR. But this is too early for us to follow. And then, of course, when natural intelligence is going to fail, we are going to use artificial intelligence to tell us who are the patients who can probably get away without surgery. But as of now, we're not there. So just quickly finishing axilla. How do we manage axilla post-chemotherapy? Again, it's divided into the locally advanced cancers and early breast cancer setting. In early breast cancer, we know there is adequate confidence in sentinel node biopsy procedures that all surgeons world over, India over, across major cities are practicing sentinel node biopsy or low axillary sampling in early breast cancer for N0 disease. For LABC, the current recommendation is to do a complete axillary lymph node dissection because we don't have data for axillary conservation in locally advanced breast cancer. So again, the problem with post-chemotherapy sentinel node biopsies, the identification rate and the patchy response within lymph nodes. So all the trials which actually happened do not meet the criteria for FNR, which should be less than 10%. So we haven't achieved that, hence we are not able to do pure sentinel node biopsy in the post-chemotherapy setting. You could improve that FNR by putting clips or putting radioiodine seeds or putting radiomagnetic seeds or doing multiple other things which is being tested world over. And with that, we may be able to improve the FNR of post-chemo SNB, offer post-chemo SNB to our patients and have better quality of life by reducing the sequelae that are associated with axillary surgery in breast cancer. And this may, in future hold true for even India. But majority of the sentinel studies post-chemotherapy say that you need to use a dual tracer method. You need to have at least 3 nodes identified. If you have clipped the node preoperatively, it will improve your FNR. And if you do not identify the SLN, please go ahead and clear the axilla completely. We completed a study of low axillary sampling in this set of patients, and we found that the false negative rate was less than 10%. And we are currently running a randomized trial where we are randomizing patients, and we have 200 patients already randomized to stop at SNB versus to go ahead with the completion axilla in early and locally advanced breast cancer who are node positive to begin with. So to conclude, post-NACT BCS is feasible in early breast cancer and select cases of locally advanced breast cancer. But after careful pre-chemo evaluation, appropriate use of imaging and meticulous response assessment at each cycle, post-NACT sentinel node biopsy or low axillary sampling can be safely carried out in pre-NACT clinico-radiologically N0 axilla. However, if you have N plus axilla before chemotherapy and that now becomes N0 post-chemotherapy, then LAS, sentinel node biopsy or targeted axillary dissection are all yet investigational, and they should not be attempted outside a trial setting or validation setting in our country. Thank you so much. I'm happy to answer questions if there are any. Yes.
Thank you very much. Thank you for inviting me here to give this talk. I think this is a very important talk, and when I was offered to speak on this, I think I jumped at it because I wanted to review the literature myself as well to see where we stand. And I think the question is there a place for anthracyclines in early breast cancer? I think the short answer of that is not just a place, but it is the mainstream. It is the core of adjuvant or neoadjuvant therapy in early breast cancer. So this is going to be the outline of my talk. We're going to talk a little bit about the introduction, speak about HER2-enriched breast cancer, luminal breast cancer, triple negative, and then kind of summarize at the end. So we're going to start with the EBCT-CG data. It was a meta-analysis in 2012, and I think it was a very comprehensive overview of how we should be looking at treating early breast cancer. This is a meta-analysis of more than 100,000 patients over 123 randomized clinical trials. I think the first question this tried to answer was, is anthracycline-based chemotherapy better than no chemotherapy? And if you look at the risk of recurrence, the breast cancer mortality and overall mortality, clearly across all of these endpoints, anthracycline-based chemotherapy was shown to be better than no chemotherapy at all. The next question to ask is that, is anthracycline-based chemotherapy better than non-anthracycline-based chemotherapy? And I think the answer is yes. Across all the same 3 parameters, you look at recurrence, breast cancer mortality, overall mortality, a non-anthracycline-based chemotherapy was inferior to an anthracycline-based chemotherapy. And now the question is, can we better on the anthracycline-based chemotherapy? And then the combination of anthracycline-taxane came into being that. Is anthracycline-taxane combination better than anthracycline-based combination? And the answer is yes. Across all the parameters, the risk of recurrence, breast cancer mortality and overall mortality was overall less in an anthracycline-taxane combination as opposed to anthracycline combination. Now, what this meta-analysis did not answer was that, can we de-escalate anthracycline? So is taxane-only chemotherapy better than or equivalent to an anthracycline-taxane chemotherapy? And I think that was not answered in this meta-analysis. So just to summarize on these meta-analysis, anthracycline-based anthracycline-based adjuvant chemotherapy is superior to no chemotherapy. Anthracycline-based chemotherapy is superior to a non-anthracycline-based chemotherapy. And an anthracycline-taxane combination is superior to anthracycline-based chemotherapy and is our current standard of care. And what I didn't show curves on, but this trial also said that the benefit of chemotherapy was not affected by age, nodal status, or ER status. So why are we talking about de-escalation of anthracyclines? Okay, we want to look at de-escalation of anthracyclines again to reduce toxicity. The questions are that our older regimes, anthracycline has been around for about 3-4 decades now, our older regimes still hold relevance in the presence of newer targeted therapies and immunotherapy? And what about the short-term and long-term toxicities of anthracyclines? We know the short-term toxicities of alopecia, nausea, vomiting, myelosuppression can be quite significant. And of course, the long-term toxicities of cardiac toxicity, leukemia, myelodysplastic syndromes are clearly long-term concerns for anthracyclines. And what we don't know is that are taxanes only enough? So to answer that, one of the studies, the US Oncology 9735 trial, looked at comparing AC4 versus TC4. Now, this was done in 2009, where AC4 was an acceptable standard of treatment, but in today's world, clearly AC4 alone, so anthracycline alone, is not a standard of care. However, having said that, TC4, that is docetaxel cyclophosphamide 4, was compared with anthracycline in unselected early breast cancers, and the majority of the patients in this subgroup were lower risk patients. And if you look at the survival curves, they were statistically non-significant. So even though the TC curve is slightly above the AC curve, the p-values were not significant much in terms of overall survival, so not much to kind of think about there. However, these studies looked at TC6. So this was a meta-analysis of 3 different trials, and they said that when we're looking at an anthracycline taxane combination being the standard, which was the standard of care after that, and this was in 2017, can we increase the number of taxanes that we're giving from 4 cycles to 6 cycles, and then say that is that going to be equivalent? So the HER2 negative patients were enrolled in this study. The number of patients were over 4,000 patients, and you can see that essentially the invasive disease-free survival was slightly better in the anthracycline taxane combination as opposed to taxane only. So this is despite 6 cycles of taxanes, anthracycline taxane combination was slightly better. So taxane only is shown to be kind of inferior when you're looking at the ABC analysis. So coming to subtype, because when we're sitting in the office, we're sitting in a clinic, we treat HER2 enriched, luminal, and triple negative as completely different disease, which they own protocols for treatment. So looking at the HER2 enriched, and I think this is probably the only place where you could start questioning de-escalation of anthracyclines in early breast cancer. So when we're talking about HER2 enriched breast cancers, the 2 main trials that define how we treat HER2 positive early breast cancer are the Affinity trial, which looked at combining pertuzumab with trastuzumab in chemotherapy, and the other one was the Catherine trial, which was an escalation of TDM1 in patients who didn't receive complete pathological response following neoadjuvant chemotherapy. And when we look at both of these trials, the vast majority of the patients in these trials, so about 3/4 of them, or more than 3/4 of them, received anthracycline-based chemotherapy. Okay, so this is something to keep in mind, that patients who received both neoadjuvant chemotherapy in the Affinity and Catherine, the vast majority of them received anthracyclines. And this was the outcome from these studies. Clearly, pertuzumab was found to be better than trastuzumab only, and escalation to TDM1 as opposed to trastuzumab in patients who did not have a complete pathological response was found to be better. But again, to reiterate the same point, that in both these studies, the vast majority of the patients received anthracycline-based chemotherapy. The other trial that looked at whether we could de-escalate anthracyclines in HER2-positive breast cancer was the Trifina study. Now, this study was not designed to look at outcomes. This study was designed to look at cardiac safety in a non-anthracycline-based regime. So it was a phase 2 study, and this study had 3 arms, which was anthracyclines concurrent with trastuzumab and pertuzumab, followed by taxanes concurrent with trastuzumab, pertuzumab. The second arm was sequential anthracyclines followed by taxane and trastuzumab, pertuzumab. And the third one is an anthracycline-free regime, which was pertuzumab, trastuzumab, and taxanes only. And this study, when you look at the cardiac toxicity, there's not much difference in all the 3 arms. The arm A had a slightly higher cardiac toxicity of about 5%, the other 2 around about 3%. And the complete pathological response was equivalent across all the 3. So you could argue that maybe if you are comfortable using complete pathological response as a surrogate marker for an outcome, for a long-term outcome, you could consider dropping anthracyclines, keeping the Trifina in mind, though it was not designed to look at long-term outcomes, but more for cardiac safety and a pathological complete response. The other trial looked at the ADAPT trial or the APT trial, which looked at giving taxanes only, so paclitaxel along with trastuzumab in very low risk HER2 positive early breast cancer. So tumors that were less than 3 centimeters in size, node negative. For this group of patients, it was not a randomized trial, but a single arm trial, which looked at the outcomes, which was excellent both for disease-free survival and recurrence-free survival. So in this really small group of patients where you really have T1 tumors or maybe T2 less than 3 centimeter tumors, you could possibly consider just giving paclitaxel and trastuzumab and omitting anthracyclines completely. So to summarize the HER2 parts, in HER2 breast cancer, we have data for both for anthracycline predominant, anthracycline-based chemotherapy, which was the Affinity and the Catherine trial, and 2 trials, Trifina and APT, to avoid anthracyclines. Like I said, Trifina is a bit questionable because it was not designed to look at outcomes, but I'm quite happy with very low risk patients to go on a taxane-free, which is to go on an anthracycline-free, which is paclitaxel and trastuzumab. Coming to HER2 negative breast cancer. So when you talk about HER2 negative breast cancer, we're talking about both luminal and triple negatives. And when we look at the adjuvant or neoadjuvant chemotherapy for HER2 negative breast cancer, I think the current protocol is we look up to CreateX and Olympia to kind of define what are the modern day chemotherapies that we tend to use. The CreateX was designed to give neoadjuvant chemotherapy followed by capecitabine in the absence of a complete pathological response. And Olympia was designed to have both neoadjuvant and adjuvant chemotherapy in BRCA positive breast cancers, and both of them had both hormone positive and triple negative patients as the inclusion criteria. And when you look at what chemotherapy they received, in the CreateX, 95% of them went on to receive anthracycline and taxane chemotherapy combination, and in the Olympia trial, 93% of them received anthracycline taxane-based chemotherapy. So clearly, both these modern trials went on to receive predominantly anthracycline-based chemotherapy, and I think if we are going to incorporate this in our practice, I think it is mandatory that we do look at anthracycline-based chemotherapy as a prerequisite. When we look at purely hormone receptor positive breast cancer, I think the most recent data comes from the monarchy that defines us how we use adjuvant therapy, and this is so the adjuvant therapy was more designed to use abemaciclib in combination with chemotherapy in patients with a higher risk of the tumor recurrence, such as more than 4 nodes or 1 to 3 nodes with larger tumors and grade 3 tumors. But what the most important part of this was that the disease-free survival continues to improve over a period of time. And when we look at those patients in terms of what type of chemotherapy they received, again in this trial, more than 90% of the patients went on to receive an anthracycline-based chemotherapy, and the vast majority of them, so about more than 80% of them, received a combination of anthracycline and taxane. So when we look at the 3 hormone receptor positive breast cancer adjuvant trials, the CreateX, the Olympia, and the Monarchy, which kind of defines how we evaluate adjuvant therapy in our practice for the hormone receptor positive. And when you look at the anthracycline use across all of these trials, they are all above 90%. So more than 90% of all of these patients received an anthracycline-based chemotherapy. When we look at pure triple negative outside of the CreateX and the Olympia, again, the most recent data comes from the Keynote 522 study, which looked at the role of pembrolizumab in the neoadjuvant chemotherapy, followed by adjuvant pembrolizumab versus placebo, and this was for triple negative cancer patients. And if you can look at the recruitment criteria in terms of whether randomization happened, having anthracycline-based chemotherapy was mandated as a part of the chemotherapy protocol. So patients went on to receive carboplatin and paclitaxel first for 12 weeks, followed by an anthracycline-based chemotherapy, whether it's doxorubicin or epirubicin. So the event-free survival was in favor of pembrolizumab plus chemotherapy versus placebo plus chemotherapy, but 100% of them went on to receive an anthracycline-based chemotherapy. So when you look at the triple negative early breast cancer in the adjuvant or neoadjuvant setting, the graph I've used for CreateX is a subgroup for triple negative disease only, and the benefit was seen across all of them for the research arm as opposed to the standard arm. But when you look at the anthracycline use in all of these, they are all above 90%. They're all above 90%. So essentially, my understanding of this is that in HER2 positive disease, we have data for both. For avoiding anthracycline, it's a little bit of an iffy data if you're using trifena and the APT. APT is fair enough, but trifena is a bit iffy data. But to give anthracyclines, you have both the affinity and the Catherine. And the trifena tells us that anthracycline in sequential with trastuzumab, pertuzumab, the cardiotoxicity is not too bad. When we look at ER-positive tumors, anthracyclines forms the mainstay of a chemotherapy backbone based on the CreateX, Olympia, and the Monarchy. If you do want to avoid anthracyclines, particularly in very, very low-risk tumors, you could consider taxanes only, but more likely 6 cycles rather than the 4 cycles as recommended by NCCN. And the reason for that is not because of strong data, but because the benefit of chemotherapy overall in a low-risk patients is low. So you probably won't lose much in terms of the benefit. And in triple negative, I think it would not be wise to omit anthracyclines. So if they're not fit for anthracyclines, they're probably not fit for chemotherapy, so to speak. So we have good data from the CreateX, Olympia, and the Keynote 522. So when I spoke about the EBCT-CG meta-analysis of 2012, I think one thing I did say that we did not have any evidence to see if taxane, in the meta-analysis to see if a taxane only was equivalent or better than a taxane anthracycline combination. And this last year's meta-analysis kind of does try to answer that. So the Kaplan-Meier on the left is taxane versus a taxane plus anthracycline. And you can clearly see that the taxane only arm is inferior to a taxane plus anthracycline. And when you look at the anthracycline versus taxane plus anthracycline, that is inferior, that we already knew. So, and I just took the interpretation as verbatim because I just wanted to read it out loud, because I think there are a lot of misunderstandings in terms of what current clinical practice and guidelines are. So anthracycline plus taxane regimes are the most efficacious at reducing breast cancer recurrence and death. Regimes with higher cumulative doses of anthracyclines plus taxane provide the greatest benefit, challenging the current trend in clinical practice and guidelines towards non-anthracycline-based chemotherapy, particularly shorter regimes such as 4 cycles of docetaxel and cyclophosphamide. Okay. So I think we have come a long way. It's taken us 3-4 decades to come here from where from the EBCT-CG first analysis to now, and I think our recurrence rates have dropped significantly thanks to the combination of both anthracycline and taxane. So I think omitting any one of them would probably not be prudent. And I don't think so over the next decade, things are going to change much in terms of our chemotherapy backbone. Thank you.
Thank you, Dr. Agarwal. If there are any questions, we can have 1 or 2. Then none.
Thank you.
Thank you, Dr. Agarwal. May I now call upon the next speaker? Perhaps one thing which is as important as the treatment of breast cancer itself in especially a young breast cancer patient is fertility preservation. And to talk on it, I would request Dr. Parinaaz Parhar to talk on fertility preservation and pregnancy in breast cancer. Thank you.
Good morning, everyone. Thank you very much for giving me this opportunity to speak on this very important topic. It's important for us to realize that fertility concerns among young cancer patients are more than legitimate, and they have a true role in determining the quality of life in the survivors. Now, it has been suggested that to preserve the full range of options, fertility preservation approaches should be discussed as early as possible before the treatment starts in these patients. Another discussion and/or referral may be necessary when the patient returns for follow-up after completion of therapy and/or if pregnancy is being considered by them. The discussion should be documented in the medical record. Now, we all know that breast cancer is the commonest malignancy in women under 40. And women under 40 years of age account for almost 5 to 10% of these cancer patients. Oncological treatment for breast cancer reduces the chance of natural pregnancy by almost 60%. Although approximately 50% of the young women are concerned about becoming infertile after breast cancer treatment, only a minority, that is only about 10%, use the fertility preservation strategies. This is of major concern because the breast cancer treatment tends to affect the fertility quite adversely. Firstly, it's a toxic effect of the chemotherapy on the ovarian follicles, which leaves them quite often infertile at the end of the treatment. The advice which is commonly given to these patients is to delay pregnancy for at least about 2 years following the diagnosis of breast cancer, which further impairs their fertility. Endocrine therapy, which is given to the hormone receptor positive patients, usually continues for at least 5 years, which further impacts their fertility adversely. And when you talk about the BRCA1 and 2 gene mutation carriers, well, most of them would be advised to undergo oophorectomy, bilateral oophorectomy, and that would again impair their fertility. Now, when we talk about the BRCA mutation and fertility preservation, approximately 1 in 10 women with breast cancer diagnosed under 40 years are carrying a mutation. 19% of the BRCA1 or 2 carriers conceive within 10 years after the breast cancer diagnosis. It's important to remember that these patients suffer from reduced reproductive potential. That is, they would have a diminished ovarian reserve as compared to others in the same age group. They would be having a lower AMH level. A poor response to controlled ovarian stimulation with letrozole protocols would be more pronounced, especially in the BRCA1 mutation carriers. The gonadotoxic effects of chemotherapy are also more pronounced in this particular group of patients, and they are more likely to experience early natural menopause, approximately 3 to 4 years earlier than the healthy women. However, if timely fertility preservation strategy is in place, there's still the possibility of having a full-term pregnancy in these patients without hysterectomy. Now, when we talk about the chemotherapy in patients who are taking treatment for breast cancer, this is a chart which is showing the effect of treatment-related amenorrhea in the female patients who are taking treatment for breast cancer. Now, it's important to understand that significantly lower rates of amenorrhea have been reported with the AC versus the CMF protocol. As far as chemotherapy is concerned, it usually causes at least a temporary period of amenorrhea owing to the damage to the developing pre-ovulatory ovarian follicles. The incidence of permanent amenorrhea following the systemic therapy for breast cancer ranges between 33 to 76%. Although resumption of menses generally occurs within about 3 to 4 months, but it may take up to 2 years post-treatment. However, the chemotherapy will invariably age the ovaries by about 5 to 10 years in terms of its reproductive potential. Presence or absence of menstruation is an inaccurate assessment of ovarian function, since regular ovulatory cycles can be maintained by only 10% of ovaries. Women might have regular menstrual cycles for several years after chemotherapy, but they may have lower likelihood of pregnancy during this period because of a significant reduction in the ovarian reserve post-treatment. So let's come to the fertility preservation options in the breast cancer patients. Now, ESHRE, which usually gives us guidelines about female reproduction and fertility preservation, has said that when estimating the risk of post-treatment premature ovarian insufficiency, the age, the proposed gonadotoxic treatment type and dose, as well as the pre-treatment AMH levels should be taken into consideration. So usually the patient's first consultation with the reproductive specialist, fertility specialist, would be to determine the gonadotoxic effect of the treatment and the ovarian reserve of the patient. Now, when we look at the available strategies for fertility preservation in breast cancer patients, there are mainly 4 main types. You have the option of oocyte and embryo cryopreservation, which usually forms the first line of fertility preservation for these patients. If the woman has a steady partner or is married, in that case, we would prefer an embryo cryopreservation. For single unmarried women, oocyte cryopreservation gives good results. Both these treatments usually require about 10 to 14 days of ovarian stimulation. It requires an outpatient surgical procedure. It is expensive, but it gives remarkable results. The second option is the option of ovarian tissue cryopreservation and transplantation. Now, this is usually used by those patients who don't have enough time at hand to undergo about 10 to 14 days of ovarian stimulation. So where we need to start treatment more urgently, that's where we go for ovarian tissue cryopreservation and transplantation. Now, this procedure is being carried out only in about 21 to 22 countries world over, and about 370 women so far have utilized it. The benefit of this is that when you do an ovarian tissue retransplantation after the surgery, you're not only restoring the fertility of the patient, but also the endocrine function of the ovaries. The last option is ovarian suppression using the GnRH agonist. This is a slightly controversial bit, and I will be covering it towards the end. Now, according to ESHRI, it's the oocyte or embryo cryopreservation should be offered as an established option for fertility preservation for women with sufficient ovarian reserve who are medically stable to undergo controlled ovarian stimulation. Women with a partner should be offered the option to cryopreserve unfertilized oocytes or to split the oocytes to attempt both embryo as well as oocyte cryopreservation. Now, usually there is a window of about 6 to 8 weeks between surgery and the start of chemotherapy. And that gives us sufficient time to try and do a controlled ovarian stimulation and preserve the fertility for these patients. If you have an early stage cancer patient, it would give us about 12 weeks in hand. Now, when possible, it's usually desirable to perform more than one cycle in order to obtain more mature oocytes and to maximize the chance for future pregnancy for these patients. Controlled ovarian hyperstimulation is contraindicated in a patient who has recently, that is within the last 6 months, been treated with chemotherapy. And that is because a recent exposure to chemotherapeutic agents may result in both morphological and genetic abnormalities in the retrieved oocytes and in a reduced ovarian response to stimulation. So the best time to give them stimulation, controlled ovarian stimulation, is in the window period between surgery as well as chemotherapy. Now, when we talk about the different treatment protocols, the stimulation protocols which are available, we have the conventional start protocol, the random start protocol, the luteal phase protocol, and then there is another protocol where we use tamoxifen throughout. Now, I'll just briefly touch all of them. When we talk about the conventional start protocol, what would routinely happen here is that we would wait for the patient's periods to start, the menses to start, and once that would start, then we would start them on gonadotrophins. Usually an aromatase inhibitor is given in order to reduce the circulating estrogen values, and once you have a dominant follicle, that is when the growing follicle is about 14 millimeters in size, that's when we add on a GnRH antagonist. Now, what this would usually result in is that we would have to wait for the patient's periods to come, and that would end up wasting a lot of time for someone who has time constraints like a cancer patient. So now we have something called as a random start protocol where you can start the stimulation as soon as the patient comes, irrespective of the part of the phase of the cycle when she comes. And this has actually shown to give almost equivalent results to what you would see in a conventional start protocol. You also have protocols where you are adding tamoxifen, which is a selective estrogen receptor modulator, which is given throughout. In some protocols, it's even given towards the end of the stimulation along with a GnRH antagonist. The whole purpose of giving tamoxifen is not only to help with the ovulation induction, but also to reduce the negative impact of the circulating estrogen values on the breast tissue. Now, this was a study which showed about the fact, which helped further reestablish the fact that random start controlled ovarian stimulation is giving us pretty good results. What they found is that when you do a random start, the number of total oocytes retrieved, the oocyte maturity rate, the mature oocyte yield, and the fertilization rates was similar to that seen in a conventional start protocol. Then why don't we go for it? There's no superiority was noted when comparing a protocol which was started in the conventional phase or in the late follicular or the luteal phase. So basically, as soon as the patient comes to us, we can start the stimulation without wasting any time. The duration of stimulation was increased in both phases compared to conventional. So yeah, the only flip side of this is that when you do a random start, the duration of stimulation might be slightly increased by about 2 to 3 days. Another thing to remember is that usually an aromatase inhibitor is given throughout these stimulation protocols because of the theoretical fear that, if you have high circulating estrogen values, you are going to put the patient at risk, especially the hormone receptor positive patients. But currently, there's no evidence that the increased circulating estrogen levels with or without letrozole treatment negatively affects the risk of breast cancer recurrence or the overall survival of these patients. But we tend to be more careful, cautious, and for most of our patients, we would be giving them a combination of letrozole and tamoxifen, along with a low dose of gonadotrophins for their stimulation. And this is a routine follicular monitoring chart for one of our breast cancer patients who had come to us for oncofertility. Now, another important concept is that of double stimulation. So the protocols which have come to our rescue for these patients is a random start protocol, and this is the double stimulation protocol. And what this involves is 2 stimulation protocols within the same menstrual cycle. So we are further saving time. We stimulate the patient, we do an oocyte retrieval. And if we feel that the number of eggs is not enough, then we start the stimulation immediately after a gap of about 3 to 5 days. And we further stimulate the patient for another 10 days and get some more eggs. So the advantage is that you have more oocytes in a short period of time. And this is how it looks. Now there's another very useful concept which can be put to use in fertility preservation for cancer patients, and that is of in vitro maturation. So conventional IVF basically involves stimulating the follicles until they reach about 2 centimeters in size, and it's based on the concept that we are helping with the oocyte is supposed to achieve maturity within the body. Whereas in vitro maturation means that we retrieve these oocytes while they're just about 8 to 10 millimeters in size, and then we mature them in the laboratory. So obviously when we are mating, we are retrieving the follicles so small, we need to stimulate it only for about 3 days. So you can see where a conventional stimulation would need about 10 to 12 days, this needs only about 3 days. So you're almost saving a week for a patient. So this involves aspiration of immature oocytes after minimal or no stimulation, followed by in vitro maturation and cryopreservation of mature oocytes or embryos generated after fertilization. So this is how the stimulation protocol looks like. We usually give OC pills for the first few days, weeks, and then, as opposed to a conventional stimulation protocol, injections are given only for 3 days. The oocytes are retrieved, they undergo maturation inside the laboratory, and then they're fertilized with the sperms, leading to the formation of embryos. Now, I would like to point out here that we are one of the very few laboratories in the country who are actually doing this process, and we have achieved pregnancy in close to about 10 patients using this technique. Now, how many oocytes do you really need to retrieve for the patient? So the answer to this lies in the age of the female patient. The success of fertility preservation depends on the number of mature oocytes collected, which is directly linked with the age of the patient and her ovarian reserve and diagnosis. So a cumulative live birth rate of about 60% is obtained in patients who are less than 35 years. If you're obtaining about 6 to 8 oocytes should be enough for them. As opposed to patients who are more than 40 years, you would get a cumulative live birth rate of only 60%, even if you achieve about 14 oocytes. So the older the age of the patient, the more the number of oocytes that you need to retrieve. Now, this is a very important study which is actually answering all our doubts about what is the safety of all these stimulation protocols for the cancer patients. So a lot of people will be concerned about what about the delay in treatment, what about the worsening of diagnosis, and very nicely they have answered all these queries. So they have said that most cycles can be completed within 14 days. The mean duration of stimulation is only about 11 days. So this is fairly safe. As far as worsening of diagnosis is concerned, patients who undergo ovarian stimulation show no increased risk of death, shorter disease-free survival or recurrence. And the post-term pregnancies also do not affect survival or recurrence risk. Aromatase inhibitors can keep the peak estradiol levels within physiological level. Some people would be concerned about the risk of OHSs and venous thromboembolism in these cancer patients, but the study says that there's no increased risk in them post-controlled ovarian stimulation. So it's actually quite reassuring. Now, since the talk is about the BRCA mutation carriers, we cannot forget about the utility of PGTM in them. Since there is a 50% risk of transmission of the mutated gene to the patient's offspring, it is important that they are given the option of a pre-implantation genetic diagnosis for the BRCA mutation during the IVF. It is believed that every woman who knows about her BRCA gene mutation, including the fertile one, should consider IVF for the exclusion of carrying the mutation in her offspring. Now, how feasible is this? It is a very feasible option, as it was proved in a study conducted in 2021, where they basically said that for patients who have a high family risk of cancer because of the BRCA mutation should definitely consider the option of PGTM. Now, coming to ovarian tissue cryopreservation and transplantation, this option is usually resorted for those patients where you don't have enough time in hand for a stimulation. Now, either an ovarian cortex biopsy or a whole ovary can be retrieved at any time during the menstrual cycle and the cortex cryopreserved. The ovarian function is expected to be recovered after 4 to 5 months, and the mean duration of the ovarian function after implantation is about 4 to 5 years. The ovarian tissue transplantation can be done either in the orthotopic site or the heterotopic site, and usually the patient needs at least 2 years for the cure before receiving the transplantation. There are 2 crucial factors for the success of the ovarian tissue cryopreservation. It's the expertise of the laboratory in cryopreserving the tissue and the age of the patient at the time of the procedure. So it's usually limited to patients who are less than 36 years. As far as, can I just get 2 minutes more? I'll just kind of summarize this. Yeah. So in patients who have a BRCA mutation, there's a very real risk of autotransplantation of ovarian tissue with cancer cells. So we have to be very mindful of that. As far as hormonal suppression is concerned, it is suggested that GnRH agonists should not be used as the main method of fertility preservation and should be offered only after cryopreservation procedures. But they can be offered to both patients who want to preserve their fertility and who don't want to, because it helps in preserving the endocrine function of the ovaries as well. So to summarize, the oncofertility counseling in the breast cancer patients, so if you have a newly diagnosed breast cancer patient who is in the premenopausal age group, firstly, we have to counsel them about the gonadotoxic risk of the therapy. Now, if a patient wants to preserve their fertility and you have more than 2 weeks available, and patient is preferably less than 40 years, then you should be doing an ovarian stimulation followed by oocyte or embryo cryopreservation. If you have less than 2 weeks available, then you can either consider IVM or ovarian tissue cryopreservation. During both the therapies, you may or may not choose to give a GnRH agonist during chemotherapy. Now, if your patient has no desire to preserve fertility, but they want to preserve their ovarian function, and if they're less than 45 years, please go ahead and use a GnRH agonist during the chemotherapy for doing that. And pregnancy and BRCA mutation carriers basically is found to be not very different from any other patient. There's just a slightly increased risk of preterm labor and congenital malformations, but it's not found to be significant. It's fairly safe for them to undergo a pregnancy. The recommendation is to wait at least 1 year post-chemotherapy completion and for starting a pregnancy. And to summarize, the possibility of benefiting from pre-implantation diagnosis and performing cancer risk reduction procedures significantly increases the chance of a genetically burdened person living a healthy life and giving birth to a child which is not burdened by the parents' germline mutation. Thank you.
Will the number of oocytes you harvest for BRCA positive patients will be more, compared to others, because chance of 50% will be there who are positive and negative, because we do send for interim stimulation, random stimulation most of the times before chemotherapy for BRCA positive. So is the double stimulation is required for them because?
Yes, that's a very relevant point. They would need. So it would be advisable whenever we do a PGTA or PGTM for a patient, we try to get as many oocytes as possible. At the same time, we have to be mindful of the time constraint. So yes, even though they are young and we would be expecting a better reserve, but BRCA as such is associated with a lower response in lower AMH. So most of them would end up needing a double stimulation.
Almost like we have to wait for 4 weeks.
No, yes, you can say almost 4 weeks. Suppose if the patient is lucky and she has a good reserve, so it basically the decision of a double stimulation would be taken after you finish your first stimulation. How many eggs did you end up with? So if it's someone fairly young, something after 14, 15 eggs should be a decent number. But then if she has an early stage cancer, then you can take some more time, get some more eggs, the more the better actually. Because your results of your PGTM would take another 2 weeks to come. So it's always better that you have enough in hand before you proceed with it. Now suppose if you end up with a situation where you have all the eggs which are affected, it is, you can discuss with the patient later the option of donor egg cycle. So that is always a last resort kind of option, but yes, when you're doing the stimulation, you might,
I'm sorry.
Yeah.
So, and also one more thing, a pre-implantation genetic testing can be offered to all sorts of genetic issues, right? Like maybe metabolic or everything we can offer.
So what we usually tend to do is we have a tie-up with a lab which does all these tests, and we send the case history to them, and they kind of let us know whether it's possible to prepare a probe. They would do a detailed analysis, they'll do a genetic counseling, and they'll find out, and then they'll give us a feedback whether it's possible for that particular case or not. But usually we restrict it to those cases where it's having a the disease which is caused is really impairing the quality of life significantly. So that has to be there for them to actually consider doing an analysis and screening those embryos. Okay?
Can I ask a question, please? So, just one second.
Yeah.
So you said broadly anybody who's less than 40 should undergo a fertility preserving procedure before the start of a...
You should give them the option.
So the point is, if you look at the recent positive trial data which was read out in SABCS, anybody who's less than 35 and has not received chemotherapy, 90% of the time they end up having as in the menstruation starts after 6 months. So to say in a blanket statement that most of these women should undergo a fertility preserving procedure before they start a treatment becomes a little tricky. First of all, so let's say you have a 32-year-old with a 1.5 centimeter or 2 centimeter a luminal tumor, and then you possibly expect her not to have a chemotherapy. And by the way, with chemotherapy also and with the GnRH, you can have a resumption of menstruation in almost a range of 85%.
Yeah.
So essentially, most of these women who will have a cryopreserved egg or ovarian tissue fertility preservation, it most of them have unuse of these tissues.
Yeah.
So, what is your take on that?
So it's more like an insurance, right? You might not need it, but you want to save it for the future. So that's where counseling the patient comes into picture. You have to first assess what is their image, what is the age, what is the stage of the cancer, what is the treatment which is planned, what is the gonadotoxicity level. Discuss it with the oncologist, then take a call. So you have to lay out, see, it's very important that you give it to the patient, you explain it to them, and you let them decide, right? So we can always tell them that, see, post your chemotherapy, based on whatever drugs are decided, this is a chance of loss of fertility at the end of it. We would not say that push everyone for fertility preservation, no. But it is our duty to give them the option and guide them adequately. So it's not a blanket statement. The thing is that, yes, please do give them the option and let them decide what they want to.
Thank you, Dr.
Yeah.
Parinaaz.
Thank you, sir.
Now,